as they say. All right, well, let's talk about Section O, because I know that's really what you want to hear about from me right now. And this section obviously documents, it says special treatments, procedures, and programs. And so it has a lot of familiar stuff in it, the special treatments and procedures and programs from MDS 2.0, Section P1A. You know, most of that is what's in Section O on the 3.0. And then, of course, the therapies in 00400, and there are some significant changes compared to 2.0 there, and so we'll definitely be spending some time talking about those changes. And you can certainly read the objectives for yourself. So the intent of Section O is to identify any of these special treatments, procedures, and programs that are listed there that the resident received. And, you know, by the way, let's all turn to Section O in our item set, because we're all going to need to refer to it. So if you haven't done that, please turn to that section right now. And the second bullet under the intent, document the type and duration of treatments during specified time periods. So this slide is just, it's almost a sort of disclaimer to just remind everybody that it's not an all-inclusive list of everything that a nursing home resident could be receiving. And the question does often come up about, you know, different things. Where do I code this on the MDS? Where do I code that? And sometimes the answer is just you don't. And so if you don't find it there and you're reading the definitions and it doesn't meet any of the definitions, then whatever it is, you're not coding it on the MDS 3.0. And so that's what, you know, it says many more therapies, procedures, and programs are available that play a vital role in health and quality of life. And you know, just because it's not captured on the MDS doesn't mean that you don't still do all the assessment and the care planning that we all know we need to do. It just means that you don't do it using the MDS. So there are several criteria that define the types of procedures that are documented in the MDS 3.0. So they include services provided by or under the direction of qualified occupational or physical therapists, skilled therapy services only, and there's also respiratory, psychological, and recreational therapy. And I don't know where speech therapy went, but we certainly capture speech-language pathology on the MDS 3.0. And you know, Chapter 3 of the 3.0 manual, the instructions for these items, there's a lot more detail in there about the requirements and you know, what's captured and all that sort of thing. And a lot of times we start to get into regulatory requirements in terms of what Medicare requires in order for a service to be considered to be skilled. And we're really not going to talk a lot about that. You're going to see some information on the slides about that. But really, if you go into Chapter 3 and you look at the instructions for Section O, you'll see a lot more information about that. And of course, the Medicare Benefit Policy Manual, and I think we have the website for that. Chapter 8 has all of that laid out for you. And so for all of that detail, don't count on this session. We're really talking more about what's captured on the MDS and how to code it, given that everybody understands what skilled means. And certainly applicable treatments and procedures do not include services provided solely in conjunction with surgical services, and that's not new, is what I'm trying to say, and non-skilled services also. And I'll talk a little bit more about that as we go along. So let's start with item 00100. So this is the special treatments and procedures and programs, and you can see what's listed there, and documenting a variety of different special treatments and procedures. And what it does, and what most people are interested in hearing about these days, is the fact that it actually separates into two columns. So I just want to preface this by saying you do capture these treatments and procedures that are listed here in O100 A through M, regardless of where the resident was when he or she received it, and even, as long as it fell into the look-back period for the assessment. You do capture it. It's just a question of which column do you put it in, which of course is what we're going to talk about. But this slide is just to remind us of how important these treatments and procedures are to nursing home residents, or in fact anybody who receives them. Certainly, they can be critical to the health status, the self-image, the dignity, and the quality of life of individuals. And so they do require some sort of special attention when they're receiving these in terms of assessment and care planning, in addition, obviously, to just marking them on the MDS. So as far as conducting the assessment is concerned, where do you get the information from to decide whether you're going to mark something in O100? Well, obviously, review the resident's medical record. There is a 14-day look-back period for this item, and so you want to look in the medical record and see if it reflects that the resident received any of these treatments or procedures during that time. And consider, as I said, treatments that were received at any time that fell into the 14-day look-back period, even if it was pre-admission. In other words, before the resident was admitted to the nursing home. And again, do not code services provided solely in conjunction with a surgical procedure. So that would be, anything that you see listed there. If it was during the surgical procedure or during routine pre- and post-operative procedures, you would not capture it. And of course, that word routine, if it was routine, obviously, if somebody had surgery and they were getting IV antibiotics in the recovery room because they actually have an infection, obviously you're going to be able to capture that. But if it's just prophylactic, that's just routine then, as they do with hip surgeries, other joint surgeries, and many other surgeries. So that's just an example of what that means. And okay, so we talked about the look-back period there. So there are 3 possible codes that you can enter in. Looking at column 1 first. Column 1 is while not a resident. So this would be services that were received either before the resident was a resident of the facility and it was captured in the look-back period, or sometimes it happens that the resident is a resident of your facility and he's actually discharged and then he comes back again and you actually end up capturing that the time that he was not a resident in your look-back period. So that would go in column 1 as well. So take that literally. He wasn't a resident of your facility at the time. As the slide says, check all treatments received by the resident. We talked about that. That would be the first one. And the code 2, the second one is the code Z, and that would be none of the above. If the resident was admitted or re-entered during the look-back period but did not receive any of the treatments listed, that's the code Z. Okay? So it's a check all that apply. Just to review, check all that apply. But if the resident did not receive it, but the resident was admitted or re-entered during the look-back period, that's when you use the code Z. And then number 3, leave column 1 blank if the resident was admitted or re-entered to the facility more than 14 days ago. In other words, if none of this falls into the look-back period at all, that's when you leave column 1 blank. Okay? So hopefully that helps to make sense. And for column 2, now this is where you document treatments that were received after becoming a resident of the facility. Now, the resident doesn't have to have received it in your facility as long as he was a resident of your facility at the time. So let's just say that he went out to a doctor's appointment, and while he was at the doctor's appointment, he received one of these things. He's still a resident of your facility, right? So you would be able to capture that in the while a resident column. So check all treatments received by the resident after admission or reentry to the facility that fall within the 14-day look-back period. Once again, check Z, none of the above if none of the treatments apply during the look-back period, and you would not leave this column blank. So that's, and let's just cut to the chase. Why do we have these two different columns? Well, you know why, don't you? Yeah, because if you check while a resident, then it can contribute to your reimbursement. And if you check while not a resident, then it doesn't. So some people say, well, why do we put it on there at all? Well, because there were some concerns with the MDS 2.0 that you didn't capture certain things when they should have been captured for care planning purposes. So that column brings in all of the treatments and procedures from that list that actually the resident received during the look-back period, but it divides them into for care planning purposes versus for reimbursement and care planning purposes. So that's column 2. Okay, so you see the whole long list of treatments and procedures there, and we're not going to go through excuse me, each and every one of those. The manual has, I think, really good definitions for each one of those. And you know what I always say, you can't do this without having the manual in front of you because you have to know all the definitions and, you know, to be completely accurate. But we did want to review a few of them with you, and they tend to be the ones that questions come up about. So, for example, A is chemotherapy. So here you would code any type of chemotherapy agent administered as an anti-neoplastic drug given by any route. So in other words, if he's getting it because he's being treated for cancer, you code it here. And that's different from another section where the instructions are code according to the classification of the drug and not the use. So that's another, you know, of the many standing rules about the MDS, and one of them is that you really shouldn't cross-reference one item definition with another unless the manual tells you to, because they do have different definitions and they were intended to. So always know what the instructions are for the specific item that you're dealing with at the time. The next one that we're looking at is oxygen. Oh, I wanted to give you an example. Sorry, the classic example about the chemotherapy. You could have somebody who's taking Megastrol. It's an anti-neoplastic drug, which has the side effect of what? That's right. It's an appetite stimulant. And so there are many nursing home residents who take this drug. They don't have cancer. They never did. But they're taking it to stimulate their appetite. So would you capture that here? No, that's right. Because the rule is that you're going to code it only if the resident is receiving it for cancer. Didn't want to forget that. Okay, now on to oxygen. So you're coding continuous or intermittent oxygen administered via mask, cannula, etc., that's delivered to relieve hypoxia. And you would code the oxygen in BiPAP and CPAP. And you know, that question has come up a lot with the 2.0. And so now you might have noticed that BiPAP and CPAP are actually on the list, so you can capture that. Because one of the questions has always been, well, do I capture BiPAP and CPAP as ventilator, respirator? And that answer has always been no, but it's even clearer now. And that could, yeah, and so that can be helpful, you know, to separate those out. But the other thing is, the question always came up, well, what if he's getting oxygen through the CPAP or the BiPAP? So now we have the answer to that as well. And just like with the 2.0, do not code hyperbaric oxygen for wound therapy in this item. The next one is IV medications. And it's really kind of interesting. I mean, this says code any drug or biological given by IV push, epidural pump, or drip through a central or peripheral port. But if you look in the manual, you know the whole thing about the biologicals and the contrast material? 2.0 folks who have been around for a while, you know what I'm talking about. It was in and then it was out. Currently with MDS 2.0, you do not capture contrast material. With MDS 3.0, you will be capturing contrast material. Okay? So that, I mean, it's clearly stated in the manual. But still, you know, do not code flushes to keep an IV access port patent. IV fluids without medications, of course, are not IV medications. Subcutaneous pumps are not IV. They're subcutaneous. Medications administered during dialysis or chemotherapy are still not captured. And, you know, this is a reimbursement thing. So some folks say, well, you know, they gave it to him right after they administered his chemo at the chemo center, so I'm going to capture it. Well, that's not really the intent. The intent is it was administered in conjunction with the chemo at the chemo center, and so you wouldn't capture it. So, you know, sometimes it's looked at more literally, that, you know, the chemo has to be running at the time. It's not quite that literal. And then dextrose 50% or lactated ringers given by IV. This is a question that has come up a lot, and CMS has kindly given us instruction on that. And of course, these are not IV medications, and so they're not captured here. And the next one is dialysis. So peritoneal or renal dialysis, and that's whether it occurs at the nursing home or another facility. It doesn't matter. You still capture it. And also you would record treatments of hemofiltration and the other treatments and procedures that you see listed there. And IVs, IV medications, and blood transfusions, one more reminder, that are administered during dialysis or chemo are considered to be a part of that procedure. And so they are not captured in their respective items under KO 500A, OO 100H, and OO 100I. And that's no different from what we have with 2.0. Okay, so we have a scenario here. And so if you take a look at your MDS and maybe code it, you know, let's take a look at what the scenario is and see how you would code it. The scenario is a resident received the following treatments 1 week prior to entering the facility. So he received chemo for cancer and IV medications. And then after entering the facility, the resident continued radiation treatments for cancer 10 days after entering the facility and stopped IV medications after 3 days in the facility. So, taking a look at the coding, see what you think, what you would do with that. So, would you capture the chemo for cancer? And which column? Column 1, right? Because it was captured in the look-back period, but it was before he came into the facility. And what about IV medications? Same thing, right? Unless it was given with the chemo, right? If it was given with the chemo, then we don't capture it. But if it's a completely separate thing from the chemo, then we would. Prior to entering the facility. No, I'm talking about the 1 week prior to entering the facility. I'm still on the first. You're jumping ahead past me. You're faster than I am. So do you see what my point is about the IV medications in the first part? Because it just says it was 1 week prior to entering the facility, and the chemo we know we're going to capture. The IV medications, we actually need to know a little bit more about that to know whether or not we can capture that. Okay, now let's go to the next one. After entering the facility, okay, so this was IV medications after 3 days, and you already told me, what do we do with that? So if it was in conjunction with chemo, again, we're not going to capture it, right? But if it was separate, yeah. If he received it in the facility because he's got pneumonia, it's separate from the chemo. And what else do we have there? Can do radiation for cancer 10 days after entering the facility. Are we going to capture that? Sure. Okay, well, here's the coding. There it is. And the IV medications, obviously, because we captured it, were not in conjunction with the chemo, because we would never make that mistake. All right, so what is 00250? Oh, the infamous vaccinations. And there really isn't very much different here from the 2.0. There's really just kind of one difference. But, you know, there really is a lot of emphasis on this for nursing homes. Look at the statistics that you see there. 60% of the, an outbreak can result in 60% of the population becoming ill, and 25% develop complications severe enough to result in hospitalization or death. And this is specific to institutional influenza A. And of course, it's the complications of the influenza that result in the death. So whatever we can do to keep residents from getting it in the first place is a really good thing. So conducting the assessment. Well, review the medical record to determine if the resident received an influenza vaccination, and if so, where it was administered. And then we also need to ask the resident if he received the flu vaccination outside of the facility for this year's influenza season. And also, you know, if you're still not sure, ask the responsible party or the legal guardian. In other words, search the entire universe and see if you can find out if this guy received the flu vaccine for the current flu season. And the rule is, if you have searched the universe over and you have no clue about whether he had the flu vaccination, give it. Because the CDC assures all of us that getting an extra flu vaccination isn't going to hurt anybody. And of course, not receiving it at all can certainly cause all kinds of complications, as we talked about, if the person does get the flu. The thing that has changed a little bit, you know how it's always said, the manual, the 2.0 manual has always said the influenza season starts when? October 1? Right. Well, it doesn't say that with the 3.0 manual. Did you notice that? And I think, I'm just guessing here, but I think this has something to do with situations that occur, like happened last year, that the influenza vaccine was available before October 1. And because of what was going on, with flu in general, folks were giving it, and that was perfectly fine. They were giving it before October 1, and that's fine. It was for the current season that, that was coming. But it was a little confusing for folks to try to figure out what to do with that in terms of, all they really needed to say was, yes, he received it. But my guess is that to alleviate that problem in the future, the CDC is going to set the flu season date every year, and they'll let us know what it is. And so it will, I'm sure be posted by the CDC and by CMS, so that we know, when the flu season officially starts. So that's just about the only difference. And it will be posted on a regular basis. So, and then this last bullet point, administer the vaccination according to the standards of clinical practice if the status can't be determined, and that's what I was referring to. So the other question that often comes up is, what about H1N1? Because there was so much of a flurry of trying to get that vaccine. Probably what's going to happen is it's just going to be rolled into the seasonal flu vaccine. I mean, that's what the plan is. So it'll just be all, because they often have more than one type of influenza covered in the vaccines that we give, so they'll just add it to that. The 00250 coding, this documents actually 3 aspects of the administration of the vaccine, and there really isn't anything particularly tricky about this. A0250A, and if you look at the question on the form, it says, did the resident receive the influenza vaccination in this facility for this year's influenza season? So if the answer is yes, you see it there on the form, code 1, yes, then you're going to continue to O0250B and enter the date. And then see where it says, you always have to read the skip patterns. It says date vaccine received, and then it says complete date, and skip to 00300A, because obviously you don't need to do 00250C that says if influenza vaccine not received, state the reason, because it was received. So you just skip that one. So that makes it kind of easy. Okay, but let's go back to 00250A. Did the resident receive the influenza vaccine in this facility for this year's influenza season? And let's say the answer is no. So in this case, what we're going to do is skip 00250B, because we don't have a date to put in there because it wasn't received. And just reading the skip pattern, it just says skip to 00250C. And that's when you need to come up with a reason for why it wasn't received in the facility for this flu season. So this is just what we're talking about. Okay, so and this is looking at 00250 more closely, and the instructions, and of course all these instructions are in the manual. Enter the date, use a 0 to complete any single-digit values. So instead of January being a blank and a 1, or a 1 and a blank, it's 01. You know that. You've seen that before. And enter a dash if part of the date is unknown. Okay, so now on to these coding instructions. For 00250C. Code a reason that the vaccine was not administered in the facility. And if you don't know the reason, or you know the reason and none of the listed ones apply, that's where you enter the 9. So let's take a little bit closer look at the reasons. So the code 00250C coded as a 1. The resident was not in the facility during this year's influenza season. So that's pretty easy to figure out if that's the case. The code 2, received outside of the facility, and that could be anywhere. He received it, but it wasn't in the facility, and so it could have been at a physician's office or a health fair or the grocery store. I know I got mine at the grocery store this year, which seemed really weird, but it was so easy. So that, they're springing up. I remember running through the Atlanta airport at one point during the flu season last year, and they had stations. I was kind of running between terminals instead of taking the tram, and so I ran across these flu vaccine stations. So if that's where your resident got it, that's the answer that you put. And then, of course, the code 3 is the not eligible because of a medical contraindication like the infamous egg allergy. And then if there is a contraindication, not like an egg allergy, which doesn't resolve, but a contraindication that does resolve, then, of course, once it's resolved, the individual should receive the vaccine. The code 4 is offered and declined, and that's pretty straightforward. They just choose not to accept it. The code 5 is not offered. And some people are really hesitant to use this one because they say that's going to look bad. But it just may be that your facility hadn't received the vaccine yet by the time the resident was discharged. So, it just wasn't offered. That's the truth. The code 6 is that inability to obtain the vaccine due to a declared shortage. And there again, once the shortage is over, then it's important to get the vaccine to anybody who wants it. And then the code 9, as I mentioned, is none of the above. If the answer is unknown or none of the answers apply. Okay, so here's a scenario, and think about how this would be coded. Mr. K wanted to receive the influenza vaccine if it arrived prior to his scheduled discharge on October 5th. Mr. K was discharged prior to the facility receiving their annual shipment of influenza vaccine, and therefore he didn't receive it in the facility. And of course, they encouraged him to receive it by some other means, but he wasn't going to be able to be receiving it in the facility. So the question is, how would you code that? Well, how would you code 00250A? That's a 0, right? It's a no. And then what do we do with B? Skip it, right? That's a good thing to do. And then what would we code C? That's a none of the above. Well, let's see. He was discharged before receiving it. They did not receive their annual shipment yet. They may have offered it. So not, and some facilities do that, don't they? Before the flu vaccine comes in, they go around and they're setting things up to see who they're going to be administering it to. So in that case, if they asked him and he wanted it, the facility didn't have it yet, then where does that go? So the 6 would be not the 6, because that's a shortage. But the 5, the not offered, would be, we didn't even offer it to him yet. And he left before we offered it. But if we offered it and the facility just didn't have it yet, that's the 9. Okay? You see the difference? Take these things very literally. We offered it, we didn't give it yet. That's not offered. We did offer it. So you have the answer there on the next slide. Okay. Where are we here? Okay, here's another one. Now this is let me catch up here. This is Mr. R. He didn't receive the flu vaccine during this year's flu season because of his known allergy to egg protein. That's too easy. What's the answer there? That's the medical contraindication. So O0250A is coded as a no, right? And then we skip B because we don't have a date to put in there. And then C would be coded as what? Yeah, that's the not eligible. Very good. Okay. So that's the influenza vaccine. So you might notice that there aren't all those dates there. You know how it is with the 2.0 that says, don't complete these items between these particular days. I mean, I'm not going to talk about that, but just for you 2.0 folks, I'm just pointing out that's not there. Okay, so the next one is the pneumococcal vaccine. And this also documents whether the resident received, in this case, the pneumococcal vaccine. And if he didn't, then that lets you know that you need to figure out whether or not he should receive it. A little bit of information here about the importance of this vaccine. Pneumococcal disease accounts for more deaths than any other vaccine-preventable bacterial disease. Case fatality rates for pneumococcal bacteremia are approximately 20%, and they can be as high as 60% in the elderly. And anybody who's ever worked in a nursing home has seen this just go through a facility, haven't you? With the flu season, and people start getting the flu, and they start getting pneumonia. So you know what we're talking about. Okay, so the pneumococcal vaccine, the decision about whether or not to give it, everybody always says, oh, it's only once in a lifetime. Well, that sounds really easy, right? So you search the world over, you know, you read the medical record, you talk to the resident, you talk to the family, you talk to the family doctor, whatever you have to do to try to find out if the resident received the pneumococcal at some time. And if you find the answer is yes, then you're done. Well, no, you're not. It's sort of implied when they say it's once in a lifetime, but you're not done, because there are situations where people need to get a booster. And that has to do with the age the person was when he got it, and whether or not 5 years have passed since then, and also if he's immunocompromised. So in your handout packet, you know, the CMS folder that you have, you will find this in there if you want to pull it out and take a look at it, because this will get you to the right answer every time. The right answer about whether or not the person needs a second, needs a pneumococcal vaccine. So you can see, yeah, and you know the rule about flowcharts and algorithms, you have to start at the top or where it says start here. You can't sort of be impatient and say, well, I think I'll start down here, because then you won't get to the right answer. Okay, so the question is, has the person been vaccinated previously? So let's say yes, he was. Is the person immune compromised? Let's say no, he isn't. Was the person less than 65 years at the time of their last vaccine? No. Okay, vaccine not indicated. That's the simple case that I described to you. But let's go the other way. Let's say, back up to the top. Has the person been previously vaccinated? Let's say yes. Is the person immunocompromised? Let's say yes. Well, have 5 years or more elapsed since the first dose? Well, if the answer is no, then you see it takes you to vaccine not indicated. But if the answer is yes, then it takes you back to, was the person less than 65 years at the time of the last vaccine, and I'm sorry, it takes you, yeah. It takes you up, I'm sorry, to vaccine indicated. Sorry about that. We already did the age. But let's say, is the person immunocompromised? No. It goes down to, was the person less than 65 years at the time of their last vaccine? Let's say yes. Now that takes us back up to have 5 or more years elapsed since the first dose. And if the answer is yes, we're back up to he needs another vaccination. So if you just keep this on hand when you're trying to work these things out, that will be a big help to you, I think. So Mr. T received the pneumococcal vaccine at age 62 when he was living in a congregate care community. Because if he was younger than 65 and he was living in his own home, he probably wouldn't have received it, right? But because he was in congregate care or an institution, it might be a different story, or it is a different story. Okay, he's now 65 years old. He's being admitted to the nursing home for chemo and respite care. So should Mr. T receive a pneumococcal vaccine? So use the algorithm and work your way through the algorithm and tell me yes or no. Okay, well, let's work our way through it then. Let's back up here. He received the pneumococcal vaccine at 62, and he's now 65 being admitted to the nursing home. Okay, has he been previously vaccinated? Yes, so we go down to, is he immune compromised? It doesn't say that he's immune compromised. It said he's being admitted for chemo and respite, so you want to assume that, okay, let's assume that he is, but you would need that information before you could make a decision, wouldn't you? Okay, but let's say that he is, because at least the group over here votes for that, so, and I'll come over here so I can hear over here too. Okay, so let's say he's immune compromised, so have 5 years or more elapsed since the first dose? No, so we're going to go down to vaccine not indicated. Okay? All right. Okay, and of course the answer is spelled out here on this slide. Okay, so we talked about how to collect the information to determine whether or not he had a pneumococcal vaccine in the past. And it's the same rule as it is with the flu vaccine. If you search the entire universe and you have no idea whether he's ever had a pneumococcal vaccine, give it to him. Because again, the CDC assures all of us that an extra pneumococcal vaccine won't hurt anybody, and the benefits are certainly documented. Okay, so the coding instructions, looking at 00300, is the resident's pneumococcal vaccination up to date? Code 0, no. If it's not up to date, code 1, yes, if it is. And you see the skip pattern there on the form. If it's no, it's not up to date, then you're going to continue to state the reason. But if it is up to date, you're just going to skip out of the rest of this. And then if the answer is no, you do go to B, and the answer options are very simple. Either not eligible due to medical contraindication, or any other reason that the physician has, or offered and declined, or not offered. So Mr. L, 72 years old, he received the pneumococcal vaccine at the physician's office last year. So 00300A would be coded yes, and we just skip out of the rest of it, right? Because he's over 65, he received it in his physician's office last year at age 71, and so he's in good shape. So here's Mrs. A. Let me find Mrs. A. Mrs. A received the pneumococcal vaccine at age 62 when she was hospitalized for a broken hip. Now she's 78 and being admitted to the nursing home. Her covering physician offered the pneumococcal vaccine during her last visit. She accepted, and the facility administered the pneumococcal vaccine to Mrs. A. So what do you think? How do we code 00300? Is her vaccination up to date? Yes. And so we're done, right? So there's the rationale. At first, when you read it, it sounds like she received it in his office, but she actually got it in the facility. All right. That's that. Okay, we're done. No, I'm kidding. So you seem to want to talk about therapies? Okay, if you're sure, I'm with you. No, really, I just think that once everybody gets used to this. Now, I just want to say right up front that, we're talking about the coding here. And I totally, completely understand that some of you have some questions and issues about policy changes and things like that. But this is what we have, and so we're going to talk about how to code it, given the policy changes. And of course, I'm going to talk about all of that. So, wow, I don't think that there's anybody in this room that needs a sales pitch on how important it is to help residents maintain as much independence as possible. We may or may not do a stellar job of that 100% of the time, but I think we all understand how important it is and really want to do that for our residents. And there's just no question that functional decline can lead to all of these things that you see listed on the slide. I mean, I can just imagine, I don't even like to think about it, I start to block it off, but I think about what would happen to me and how it would affect my life if I simply, I know it's not that simple, but if I simply lost the ability to move from a sitting to standing position independently. Just that one functional change would just be devastating. And of course, our residents have that and much more. So, but it's like I said, I know that you don't really need a sales pitch on that particular issue. So as far as 00400 is concerned, there are regulations that I referred to about what makes something skilled, and you need orders from the physician, and all of that stays the same. Those are Medicare requirements, and requirements for not only Medicare, some of them, but for other reasons as well. And that all stays the same. But the slides do review some of that. So it says the qualified therapist, physician, and nursing administration are responsible for determining the necessity for therapy services to be provided and the frequency and duration of the therapy services. And rehabilitation and respiratory, psychological, and recreational therapy, which are captured here, can help residents to attain or maintain their highest level of well-being, which, those are the marching orders for nursing homes, right? That's the core of OBRA 87, that we will do that. And also can help to improve their quality of life. Certainly, quality of life is hugely impacted by functional problems. So the purpose of 00400 therapies is to determine therapies the resident received, the mode for each therapy received, how many minutes the resident spent in each mode, and I'm going to define mode for you here. during the look-back period, and the number of days of therapy during the look-back. And the definition of days, as you'll see on the slides coming up, hasn't changed. There still has to have been 15 minutes of whatever the particular therapy discipline is in order for it to be captured as a day. The applicable therapies. Medically necessary therapies that occurred after admission, readmission to the facility. That's an important point. You don't capture anything that occurred prior to admission. Ordered by qualified staff based on a qualified therapist's assessment and treatment plan, documented in the resident's medical record, care plan periodically evaluated. And of course, as long as the individual is a resident of your facility, you count it whether it occurred in your facility or outside of your facility, as long as it's captured in the look-back period. So as far as conducting the assessment is concerned, of course, reviewing the medical record and making sure there has to be a therapy eval to be able to have therapy minutes. So you review the eval, the treatment records, recreation therapy notes, mental health professional notes. In other words, any documentation that pertains to the category that you're capturing here in 00400, the discipline. And of course, consulting with each of the qualified care providers. And then include only services provided, we talked about that, once the resident was actually a resident of your facility. Do not include therapies that occurred while the resident was an inpatient at a hospital or recuperative rehabilitation center or other long-term care facility. And of course, you don't capture any therapy that was provided as home care or community-based services. So back to that issue of include only therapies provided after readmission if the resident returns from a hospital stay. So this is just to clarify, a new initial evaluation has to be done each time a resident is readmitted to the hospital to a hospital inpatient stay and then returns to your facility. And count only therapies, again, that occurred since readmission, reentry, and after the initial evaluation, because as most of you know, you don't count the minutes from the initial evaluation itself. So these are the applicable therapies that you see here. Respiratory, psychological, recreational therapy must meet the requirements for skilled therapy outlined in Chapter 3 of the RAI manual. And, we're not going to go through all of those now, but of course, providers of Medicare Part A services, Medicare Part B, Medicaid, we're all required to know what constitutes skilled care if we're going to be providing skilled care. And we need to know what the rules are for all of this. Second bullet, includes services provided by a qualified physical occupational therapy assistant employed by the facility only if under the direction of a qualified therapist. Medicare does not recognize speech-language pathology assistants. That's why they're not included there. And do not include therapeutic services that are not specifically listed in the RAI manual or on the MDS item set, even if provided by specialists. On the next slide, include only skilled therapy services for speech, PT, and OT. And you see some of the criteria here. Skilled therapy services must meet all of the following, and there are probably even more, when you get into the Medicare Benefit Policy Manual. Ordered, if it's Part A, it has to be ordered by a physician. If it's Part B, it has to be certified by a physician. directly and specifically related to that active written treatment plan we talked about, it has to require the judgment, knowledge, and skills of a therapist. And that's something, to be very much aware of. I kind of think of it as if somebody trained in restorative nursing practices could safely do it, then it's not skilled for rehab. And it should be provided, and these are the regulations, provided with the expectation that the condition of the resident will improve materially in a reasonable and generally predictable period of time. And this is one of those regulations that I find that a lot of people really aren't aware of. We all know that from week to week we're looking for improvement, but a lot of folks just weren't real clear that that was actually written into the regulations somewhere, and of course there it is. Considered to be specific and effective treatment for the resident's condition. In other words, it has to meet the standard of practice or the standard of care for that particular condition. And it has to be reasonable and necessary for the treatment of the resident's condition, including the amount, frequency, duration of services, and furnished by qualified personnel. And I just really encourage everybody to be sure to check out the Medicare Benefit Policy Manual. You can always ask your Medicare contractor, the fiscal intermediary, or the Medicare administrative contractor if you have questions. But obviously, being intimately familiar with the criteria for understanding what makes something skilled is critical. And non-skilled services do not include services provided at the request of the resident or family that are not medically necessary. And what that means is, sometimes you'll have somebody who's on Part A and they meet their goals or they plateau and they come off of Part A because they don't seem to have any more potential for improvement, but the family wants to continue with skilled therapy. Well, and they're going to pay for it. Well, in that case, you would not count those minutes because they're not considered to be medically necessary at that point. Of course, don't include maintenance treatments or supervision of aides performing maintenance services, and do not include services provided after the resident has been discharged from rehab. That might be their transition to restorative nursing program. And the therapists or the therapy assistants can continue to do the treatments if they want to, but they can't capture them here. It would have to be captured as restorative if all of those criteria are met. So let's get down to business here. There are 3 modes of therapy that have to be captured. And you can see that under 00400 A, B, and C, you see 1, 2, and 3. Individual, concurrent, and there's a different definition. Actually, Medicare Part A recognizes concurrent, Part B does not. So it's important to keep that in mind, and we'll talk a little bit more about that. And group therapy and Part A and Part B have a little bit different take on those as well. So, wait a minute. Sorry. Individual therapy. I think we all know what individual therapy is, right? That's one therapist or therapy assistant, except for speech, and one resident, and that therapist or therapy assistant isn't doing anything else. That's one-to-one, right? And the last bullet point there, the treatment may be provided at intermittent times throughout the day, and it's still individual therapy as long as these criteria are met. Now, concurrent therapy. There's a definition for this, a very specific definition now. 2 residents treated at the same time, not performing the same or similar activities. Both residents must be in line of sight of the treating therapist or assistant, and it doesn't matter who the payer is. It's still concurrent. So remember I said Part B doesn't recognize concurrent therapy? But if you have somebody who's on Part A And he's being treated under this definition of concurrent therapy, but the other person has Part B. It's still concurrent therapy for the Part A person, even though Part B doesn't recognize it. For Part B, it would actually be group. But looking at that Part A person, he's getting concurrent therapy, okay? So then for Part B, you can see concurrent therapy. Treatment of 2 or more residents at the same time is documented as group treatment, regardless of payer source. In other words, regardless of what other payer sources are in the group, it's still group for Part B. And group therapy for Medicare Part A, this definition hasn't changed. And you see what it is there on the slide. For Part B, it's a little bit different. And you can see there's just a little bit of a difference there. The thing about group therapy is that there is a 25% cap. In other words, per discipline, when you add up the total therapy minutes, group therapy can be no more than 25% of that total. And right now, the therapists are having to calculate that cap and make sure they don't go over it. They're not going to have to do that anymore. What's going to happen with all of this, and the reason that you have the 3 different modes, is because the software that calculates the RUG category is going to add 100% of the individual minutes, 1/2 of the concurrent minutes, and then it's going to add, if there are group minutes entered there, it's going to add the group minutes not to exceed the cap. So it's going to do all the math. So I really want to emphasize, whoever is filling out the section and the individual, concurrent, and group, you're putting in the actual number of minutes that the resident received. So for concurrent, and this is really important, for concurrent, let's say that a therapist was doing concurrent therapy with 2 residents for 60 minutes. Each resident gets 60 minutes towards the total on the MDS. The software will come along and cut it in half for each one for Part A, okay? So that means the therapists do not cut it in half before they enter the minutes, because then the software is going to come along and it'll cut it in half again. That's what I call a bad outcome for the facility. And the same thing with group therapy. Whatever actual number of minutes each resident spends in group, that's what goes on the MDS, and the grouper software will take care of the math. OO400, determine the minutes. Do not include time spent on documentation or initial evaluation. Do include time spent on reevaluation as a part of the treatment process. Do include time required to adjust equipment or otherwise prepare for individualized therapy. Split time as deemed appropriate. And what this is referring to is co-treatments. That's what this bullet point is talking about. So if you have 2 clinicians from 2 different disciplines treating a resident at the same time, let's say OT and PT are treating together for an hour, they have to decide how many minutes each gets to total no more than 60 minutes. So that's a co-treat. Okay. And of course, you know, a resident may receive therapy via different modes during the same day or treatment session. They could have some individual, some group, you know, some concurrent. Just have to keep track of which is which. So treatment time starts when the resident begins the first treatment activity or task. This is not new. It ends when the resident finishes with the last apparatus or intervention or task. Count the total minutes, including time spent for therapeutic purpose. Do not include any other type of break. So for example, if the resident takes a therapeutic rest with monitoring to control the heart rate, for example, then that would be included. But non-therapeutic, like a bathroom break or a non-therapeutic rest, would not be counted. Okay, so the therapist and assistant must determine the mode of therapy and time the resident received for each. Include only skilled therapy minutes, total minutes of intermittent individual therapy services into a daily count. So like I said, the individual services could be several different times during the day. You just add them all up for that day. Record the actual minutes. Do not round to the nearest fifth minute. Do not do anything else except record the actual minutes. Now, when it comes to therapy aides and students, and this is a big change. I mean, I didn't even realize how many facilities were using therapy aides to deliver skilled care, but it's not skilled care. So the only time, as the second bullet point says, that you can include, now this is not therapy assistants, okay? Please be sure to hear me say that. This is therapy aides, not therapy assistants. The only time a therapy aide time can be included is when they're setting up for skilled services to prepare for individual therapy. And for example, setting up for the treatment area for wound therapy, or setting up equipment, or directly in preparation for a treatment. So the therapy aide must be under the direct supervision of the therapist or assistant. And there's a lot of information in the manual about therapy students in Chapter 3. I know that there have been questions, and so there's a lot of information that's been added in there. So you might want to take a look at that. Well, let's do a practice scenario here. So we have Mrs. V, and you might want to just take your pencil and write these things down. I don't know. I just always assume everybody's as visual as I am, but that's what I have to do. I have to write it down to be able to see it. Mrs. V, whose stay is covered by Part A, begins therapy in an individual session. And after 13 minutes, the therapist begins working with Mr. S, whose therapy is covered by Medicare Part B. Mrs. V continues with her skilled interventions and is in line of sight of the treating therapist. The therapist provides treatment at the same time to Mrs. V and Mr. S for 24 minutes. Mrs. V's therapy session ends at this time, and the therapist continues to treat Mr. S individually for 10 minutes. Okay, so the question is, how many minutes of individual therapy did Mrs. V get? 13, right? That was the only time Mrs. V was alone with the therapist receiving treatment. How about concurrent minutes for Mrs. V? 24. That's the number of minutes that the therapist was treating both of them together. And what about group minutes for Mrs. V? 0. She didn't have any group. Okay, well, let's look at Mrs. S. Mrs. S? Mr. S. I didn't mean to do a sex change there, right in the middle. So how many individual minutes did Mr. S receive? 10, because that's at the end there is the only time he was alone with her. Okay, how about how many concurrent minutes for Mr. S? 0. Very good, from all over the room. That was great. Why 0? Because Part B doesn't recognize concurrent. So how many group minutes for Mr. S? That's the 24, drops down to group. Exactly. And we're going to do some more of these tonight, too. let's see, what else do we have here? Okay, very good. So this is what the coding looks like. And hopefully you've been looking at the MDS all along as I've been talking and following along. But you see where the minutes go there in the left for the 3 different modes. And then for respiratory, there aren't any entered here. And then, okay, so here's another one. So Mr. E is on Part A. Wait a minute, I got to catch up here. I don't want to forget to tell you anything. Okay, Mr. E is covered by Part A. Mr. E received physical therapy for 20 minutes per day for 4 days during the look-back period. And during 2 of these sessions, the therapist began working with Mr. N on a different activity while keeping Mr. E in line of sight. Mr. E and Mr. N received therapy at the same time for 9 minutes in the first session, 12 minutes in the second. Mr. N did not receive any other physical therapy services at the same time as Mr. E. And Mr. N is covered by Part B. So, how should 00400C be coded for Mr. E? So how many individual minutes did Mr. E get? Okay, it's spreading. I need to hear from the middle of the room. How many? Everybody seems to like 59. And I think that's right, because remember, there were 4 sessions of 20 minutes each, but for 2 of them, part of the 20-minute session was concurrent, right? So there was 9 minutes once and 12 minutes another time that would be calculated as concurrent. So what's left is 11 and 8, and then 2 20-minute sessions that add up to 59. And so then how many concurrent minutes? That's the 21 minutes, right? The 9 and the 12 that I talked about, that the therapy was between the 2 of them. And the, what are we missing? Group minutes. For Mr. E, right. He didn't have any group. Okay, and so this is the coding. And of course, he received therapy for at least 15 minutes on 4 days. Okay, and then for Mr. N, does he have individual minutes? How many? He didn't even have any individual minutes, did he? How about concurrent? 0. Why? Oh, he's Part B, of course. So what about group? 21 minutes. Very good. And so this spells that out there. Okay. Okay, so the 00400 practice activity. You know, when I first started learning this, this made me crazy trying to figure this out. Now, some of you are saying, well, Rena, what's wrong with your brain? It's not that hard. Well, you're right, but we don't all think in these terms. And so, and if you come tonight, you know, we're going to do some practice activities as well. But what I'd like to do is ask you to think about the approach to this. I mean, you can be faced with a lot of information, and you have an activity sheet there in your handout. And, you know, you can feel maybe a little bit overwhelmed by it. But if you think about how we just went through those practice activities and pulled out the information that we wanted, and I have to write it down. I mean, I put each resident's name, and I put I, C, and G, and I just write them down in columns and then add them up when I'm done because that's what I have to do. It might be more intuitive to some other folks to do it a different way. But I just encourage you to start looking at it in terms of, being able to identify, oh yeah, that's individual, or oh yeah, that's concurrent. For example, the example that we just looked at, where there were 4 20-minute sessions, but for 2 of them, portions were concurrent. So you have to, be able to sort of spot that and pull it out. But, I mean, it's not about the math. Some people have said to me, well, I'm just really not good at math. It's not about the math. It's about being able to identify the mode. Okay, so let me find my practice activity. We're reading the scenario. And then once you've read this scenario, I'd like to ask you to calculate the minutes for speech-language pathology services, ending up with what would go on the MDS for speech. Take a look at what we have here, because we're just doing speech, and we'll do the rest of it tonight. Oh, good. Well, if you did them all, then you're all set. And you're fast. But let's take a look at speech for right now. We have a lot of information there about the type of treatments, the dysphagia and cognitive training and techniques. And it's wonderful that the resident's getting all of that, but it's really not pertinent as long as it's skilled, right? And we're assuming that everything is skilled here. So what we need to do, what I did, like I said, is I put an I for individual, a C for concurrent, and a G for group, and I just went down and I found, okay, are there any individual minutes there? So where are they? So for the dysphagia, right, how many minutes there? So it's Monday through Friday, so that's 5 days for 30-minute sessions each day, so that's 150. And where else do we have individual minutes? Oh, speech techniques, right. And how many minutes? 40, because there are 2 sessions, 2 days at 20 minutes. So we just add those up, and we come up with the total number of individual minutes. So looking at 00400A, next to individual minutes, we're going to enter the number of minutes, and so we're just going to put 190 in there. And then where are the minutes for, are there any concurrent minutes? Under cognitive training, right? Anywhere else? There are 2 35-minute sessions, right? So that's 70. And what about group? Yeah, we can see under cognitive training, Tuesday, Wednesday, Friday, 25-minute group sessions. Okay, so then we go to 00400, and we enter the minutes there. And you can see it here and how they're entered to the right, not justified to the left, but to the right. And the group minutes. Okay, and then how many days of therapy do we have for 4? 5 days, because each one of the days had at least 15 minutes, right? So we get to capture all of those. Okay, now as far as 00400A5, therapy start date. So do you know what goes in there? The definition of the therapy start is I heard a few folks say it, is the date of the initial eval. So what date is that for speech? So that's 10/6, right? And then the therapy end date, well, look at the definition, the date the most recent therapy regimen, in this case for speech, since the most recent entry ended. Well, it hasn't ended. So what are we going to put in there? Dashes. That's what it tells us right there on the form. So, oh, there they are. The dashes are on there. It's the date that is not visible. Okay. So is this making sense to you? Okay. Although I do understand if you're not a therapist and you're saying, I'm really glad therapy's doing this. But I also know that there are a lot of MDS nurses and others in various facilities that are tasked with double checking. It's like an audit, which is a really good thing to do because people make transcription errors, and so it's a really good idea to understand how to do it so you can be that double check for your facility to make sure.